Can you kind of do a few things for us, like define what it is for us, what some of the symptoms might be, what kind of lab testing do you do?
Puberty number 1 is that first transition phase that a woman, or female puberty, that a woman goes through where she transitions from the girlhood years into the reproductive years.
If you're in perimenopause, about how long does that usually last, and when do you make a decision at that time to put people on hormones?
The first hormone that many women lose is progesterone. And when you lose your progesterone, some women feel more anxious.
Hey guys, welcome to the show. And before you do anything, if I can just ask you a big favor, if you are on YouTube, please hit that subscribe button now. It goes a long way in helping us get our message out there and get great topics to you and others. And speaking of great topics, today I want to talk to you about a health issue that I think is particularly important if you are a woman in your 30s, 40s, 50s, or beyond. And hear me out on this. Do you ever feel like as a woman, some days your body just feels totally normal and familiar, and then other days it feels like it is operating under a totally different set of rules? Well, I'm here to tell you that there could be a medical reason for this. My guest today is going to talk to us about 10 plus symptoms that you could be experiencing as a woman, and your doctor may be completely missing the diagnosis. And trust me, this is not something you want to have happen. It happened to me. I was in my 40s. I was getting shuffled around from doctor to doctor for over a year. I was diagnosed with panic attacks. At one point, I was told I might have a heart condition. I even ended up having a cardiac catheterization. And for those of you who don't know, it's actually kind of a scary procedure. And by the way, it ended up being totally normal. And somewhere in the middle of all this chaos, a physician said to me, you know what, you might be having symptoms related to a perimenopausal hormone deficiency. And I was like, okay, that sounds pretty simple, but okay, I'll try whatever. And the physician put me on something, and within about 2 weeks, I felt completely normal again. So my guest today, Dr. Ann Greider, is a board-certified OB-GYN, and she is here to demystify the topics of perimenopause and menopause for us. And in so doing, she may just save you a lot of time, effort, energy, and money. And more importantly, she's going to talk to us about some treatments that can help with mood, cognition, your sleep, maybe even your weight, your sex life. So today, as I said, I have Dr. Greider with me, and she has over 30 years of experience in OB-GYN. She belongs to a very large practice here in Louisville, Kentucky. They have 9 medical doctors, 13 other medical providers. They do all the things under one roof. They take care of people in their teens and into the elderly years. They do mammograms, ultrasounds, labs, bone density testing, and more. We are so happy to have her here today, and she is a Menopause Society certified practitioner. She's post-call. She's such a trooper for being here to talk to us about these important topics for women. Welcome, Dr. Greider, to the show. Hi.
Hi, thank you. I appreciate you having me on. This is a topic near and dear to my heart.
Great. I know. I mean, every time I go into your office, I just feel like I get so much good information about anything I ask. So I was like, she's the perfect person to have on here.
Yeah. Well, menopause, perimenopause, if you live long enough, it's going to affect every woman. So every one of us,
right?
Every woman in someone's life, if you're someone's mother or brother or sister, parent, it's going to affect you at some point. So it's good for everybody to be well informed and educated.
I agree because during the introduction, I really talked about women, but for sure, I mean, your spouse or your parent or whomever may be
kids,
affected by
siblings,
this, right? And
coworkers.
Because like in my case, I was going through all of this for a year. I was in emergency rooms I was like, I think EMS had to come to my house, and it was terrible. And yes, it can be a strain on the entire family. So yes, let's start at perimenopause. And can you kind of do a few things for us, like define what it is for us, what some of the symptoms might be, what kind of lab testing do you do, and maybe other testing?
Sure.
Yeah.
So the way I like to describe it to people is perimenopause is puberty number 2.
Okay.
So puberty number 1 is that first transition phase that a woman, or female puberty, that a woman goes through where she transitions from the girlhood years into the reproductive years.
Right.
And that's a several year process. And you start noticing some physical changes early, and then it's a few years later that you start having cycles and regular periods. Well, at the end of the reproductive years, women go through a transition that is a transition out of the reproductive years, and we call that perimenopause.
Okay.
So puberty number 1, then you have puberty number 2. And just like puberty number 1 can start at a variety of different ages, a big range, puberty number 2 or perimenopause can as well.
Mm-hmm.
So in perimenopause, the big thing that affects most women is the hormone swings. So it's one day your hormones are up and the next day your hormones are down. And then in a few more days they're up and they're down. And the swings can start late 30s, but really anybody in their 40s is perimenopausal.
Right. And that's when it hit me.
Yeah,
Mid-40s.
at any age. And so different things start changing. And for the average person in the early 40s, you know, sleep may not be quite as good, or you may have some hot flashes or night sweats, particularly right before a period starts. But periods are usually still somewhat regular in that perimenopausal time. And then you get a lot of the other symptoms that are like puberty number 1, so more acne and more breast tenderness and more PMS, and just everything feels off. And there's not really a good test. There's not a test to say, okay, well, I'm perimenopausal, because one day your hormones are up and one day your hormones are down, and it depends on where you are in your cycle. Right. And it's the swing, it's the bottoming out. So the days that your hormones bottom out, if you did blood work, you might test in the menopause range. And then days that your hormones are high, you may be like, no, I'm not. And so it's not just a one lab test, or it's not necessarily a series of blood tests that tells you where you are.
Okay.
And people have to be careful, because there's always somebody out there that's willing to sell you a really nice sales pitch.
Right.
Because we're all searching, because we all feel off. We feel like we're going crazy. We feel like our body's doing something different, and we feel like it's out of control. Right. And everybody's searching. And so there's plenty of hormone clinics and places that you can go, and they'll start checking your labs, and they'll start following things, but you really don't have to have all of that.
Do you typically you don't check anything? Or you do some rule outs? Or what do you do?
I do some rule outs for other things like thyroid and some other medical things.
Sure.
But if I really think that it's just perimenopausal symptoms, there's not really a lot of lab tests that we do. The first hormone that we lose in that menopausal transition and perimenopause is our progesterone. And so when we talk about the hormones, the big ones that we talk about for female menopausal hormones is estrogen and progesterone. And I'll talk a little bit about when you start losing each one, what symptoms you have, and then we can't really have a talk about perimenopause and menopause without at least mentioning testosterone a little bit.
Sure.
But the first hormone that many women lose is progesterone. And when you lose your progesterone, some women feel more anxious.
This was what my problem was.
They feel more anxiety, and they have problems going to sleep. So sleep and anxiety are the big ones for the progesterone. And when we are treating with progesterone, if we're using a micronized progesterone that crosses the blood-brain barrier, it crosses and affects the GABA receptors, so it has a calmant and a sedative effect.
Okay.
So we use progesterone to help that sleep and to help a lot with anxiety.
What do you mean by micronized? Can you explain that to us?
So there are synthetic progestins that would be like your Provera, your Agestin, and then progesterone, the micronized progesterone, is more bioidentical. And the term bioidentical, it gets confusing, and that's used a lot in a lot of marketing.
Sure. Yes.
A lot of marketing attempts to get your money.
Yes.
But the micronized progesterone is more similar to how your body makes the progesterone.
Okay.
And it's the one that crosses the blood-brain barrier. So if you're taking a synthetic progestin, like a Provera or an Agestin, it has other effects similar to the progesterone, but it doesn't have that common sedative effect.
Okay.
So that's one of the big differences. And then our estrogen levels start fluctuating. And so when estrogen levels are higher, people sometimes will get some breast tenderness. When estrogen levels start bottoming out, that's one of the big symptoms of hot flashes and night sweats. So the vasomotor symptoms. So you're hot a lot. Then we're fluctuating for several years for many people.
Yes.
Several years in the perimenopause, and then when we hit menopause, it's not one day you're perimenopausal and the next day you're menopausal. It's not exactly like a switch is flipped. But we define menopause as a year from your last menstrual period, when that last menstrual period was when your ovaries were shutting down.
Yeah.
So in your reproductive years, your ovaries make estrogen, and then when you ovulate and release an egg, you make progesterone. And they have some different functions for reproductive purposes, for getting pregnant and maintaining a pregnancy.
Right.
But what we talk about for the menstrual cycle is it's the estrogen building things up in the uterine lining, and then the progesterone, when you ovulate, thins that down. So the menstrual cycle is building up and thinning down, building up and thinning down, and it's cyclic based on when you ovulate. And when we start getting into that late perimenopausal time into menopause, women are not ovulating regularly because their ovaries are shutting down. And so when their ovaries are shutting down, they start losing their estrogen as well. And then that's when more of the brain fog, disrupted sleep from heat, muscle aches and pains. There's a whole syndrome now of musculoskeletal syndrome of menopause that women used to just be blown off for, that now we know that's because of lack of estrogen. And then later, usually later in the menopause years, then we start losing our estrogen in our genitourinary system, and so we start having a lot more vaginal dryness and urinary symptoms, and many women can benefit from vaginal estrogen as well.
Right.
But let's talk a little bit about how we define menopause and when we say someone is menopausal. So when we say you're menopausal when you've been a year without a period because your ovaries have shut down,
Right.
average age for us here in the United States is 51 to 52.
Okay.
So if the average age is 51 to 52, then there's going to be plenty of women that are 47 and they've had their last menstrual period. We're going to have plenty of women that are 55 or 56 and they're still having some periods. And the least likely scenario is that you truck along and you just have a period every month and then you just never have another one. Every once in a while, somebody will do that.
That was me. Yeah.
Every once in
50,
a while, somebody
totally
does that.
cut off, and everything was totally normal before that. And I think that was one of the reasons I didn't know that I was perimenopausal, was because I was having such regular cycles. But anyway, go ahead.
Yeah.
All right. So 47 to 50s.
You know, we really define early menopause as if you've had your last menstrual period before 45.
Okay.
And we call it premature ovarian insufficiency. So like an abnormal, like some people are like an early starter on their periods, but An early menopause person is 40 to 45, and an abnormally early menopause is less than 40.
Okay.
So then that's a whole nother discussion of things that we start working up and looking at for some other medical things. But so, every once in a while we have somebody who will have a period and they just never have another one.
Yeah.
They're done.
Yeah.
But most people take 2 or 3 years. So they'll go along and then they'll space out a little bit. And then they start going a few months and having some hot flashes in between. And then they'll kick back in for a few months. And it takes the average person 2 or 3 years to get their year without a period. So you don't always know when is the last one. And I think historically a lot of women the last few years have been told, like, well, you're not menopausal yet because you haven't been a year without a period. So they are not offered hormone therapy to help them feel better.
Right.
Because during those months that your ovaries are shut down, you have symptoms of full-blown menopause. And then when you start feeling a little bit better and you're thinking, oh, I'm done with this, then your periods are probably going to start back. So they're back and forth and back and forth.
Right.
And the symptoms of menopause, so the hot flashes, the night sweats, the musculoskeletal, the brain fog, that is most intense for most people early after that last menstrual period, and then it will gradually get better for most people. So 80% of people get to the point that they don't really need anything hormonally to feel better. About 1 in 5 women forever will feel better if she takes estrogen.
Okay.
And in those people that feel better, I've got a few people that say, oh my goodness, life's not worth living if I don't have my hormones. Like, I don't care. I don't care if I've got some reason I can't take it. Like, I can't function without.
Right.
And then there's a whole group of people in that 20% that are like, well, I feel better on them, but if I have a reason I can't take hormones, then then I can make do.
Well, tell me this. So I don't know. I think I'm in that category where I feel way better on stuff. And again, I'm sure you see everything across a spectrum of things. But I guess I am curious, like, okay, so this perimenopausal period transitions into the menopausal period. If you're in perimenopause, about how long does that usually last? And when do you make a decision at that time to put people on hormones? What would you possibly put them on? And would you kind of have a discussion like, okay, this is the first step, and you're going to graduate to, in probably 5 to 10 years, to menopause, and we'll change the things at that point. Like, so
that's a good question. So it's very individual for each person. And so, unfortunately, the earlier you start perimenopause, usually the longer it lasts.
Okay.
Because the average age is still pretty consistent.
In the mid-40s?
Well, the average age of menopause is still pretty consistent.
Okay. Yeah. Okay.
So whenever you start, so if you start perimenopausal symptoms in your late 30s, you're probably still going to go until about 50. And if you start your perimenopausal symptoms in your mid-40s, you're still going to go to your early 50s, probably.
Okay.
You can look at the women in your family, blood relatives, and if they all were menopausal before they were 50, or if they were all menopausal, last menstrual period, in their mid-50s, then you kind of have a little bit of a gauge.
Okay.
But people try to do some different blood tests to see, to really predict, but there's not as much utility with that. It's just treat people where they are. So, treat people where they are. So it depends. So in perimenopause, it depends on what is bothering somebody the most.
Okay.
So many times periods are erratic.
Okay.
In perimenopause, they may still be heavy. People may still need birth control and contraception. So hormonal birth control, like a birth control pill, is a wonderful treatment for many women in perimenopause. Use it all the time. So it treats the acne, it treats the PMS, it treats a lot of those symptoms.
Okay.
For some women, when they really start having vasomotor symptoms, the estrogen that's in a birth control pill is a little bit different than the estrogen, even though they have the similar name, is different than just estradiol that we typically use for just hormone replacement therapy. So sometimes we tweak that around a little bit if somebody has vasomotor symptoms, or if somebody has sleep problems or more anxiety. We may try to give them the micronized progesterone instead of a synthetic progestin that is in a birth control pill.
And when you say micronized progesterone, does that mean a cream?
No, it's a pill. It's a pill. It's an oral pill.
All right.
Yeah, it's an oral pill.
Yes, okay. So I'm trying to think of what I was on, and I think I was on a pill.
Yeah, we don't absorb progesterone consistently through the skin.
Okay.
So I do not prescribe creams, progesterone creams, very often. Very rarely do I prescribe them. The other big thing that we need to make sure that everyone is aware of is just the medical part of having a uterus. And if you take an estrogen, and you don't get a progesterone or a progestin, then you're getting estrogen stimulation of the uterus. So if you have a uterus and you have estrogen, you have to have a uterine protector to keep that uterine lining thinned down. And a whole discussion is going to be for us to talk about the medical benefits and the pros and the cons. But one thing that I will mention is uterine cancer is associated with unopposed estrogen. So if a woman is getting estrogen and not having progesterone or progestin protection to keep that lining thinned down, then that woman is at risk for uterine cancer.
Are you saying like if they're prescribed just estrogen?
If they are prescribed just estrogen alone, and they have a uterus, so this does not apply to people who don't have a uterus, hysterectomy people. But if they just have an estrogen and they have a uterus, they have to have some sort of a uterine protector. So that can be a hormone IUD, like a Mirena IUD. That can be, you get it in birth control pills with the progestins in that. That can be a synthetic progestin, or that can be the micronized progesterone. And actually the synthetic progestins are better uterine protectors than are the progesterone. But you have to be getting both. And so in that perimenopausal time, when women may be having irregular periods, they may need contraception, they may need something different than the typical hormones that we give after menopause, because the needs are different, the physical and the medical and usually it's the bleeding. And if you give menopausal hormone therapy to a perimenopausal woman, you may cause her to have more irregular periods because you're not giving her a strong enough progestin to suppress the periods. That's why either an IUD or birth control pills are sometimes better because they treat the bleeding.
And so what I hear you saying here is like you've really got to work with your provider, and I would again, I'm going back to just some personal experiences here where at one point I do think maybe I wasn't on enough, I forgot what you said, but where you get the irregularity, and maybe I needed to be on a slightly higher dose of one of the hormones. Which one was it?
Well, so if you don't have a strong enough progesterone or progestin, then you get irregular bleeding taking the estrogen.
And the other thing, again, I'm just trying to remember back from when this happened to me, but like, so when I was on the progesterone therapy, it was like for part of the month. Does that sound right? And then are you typically...
It can be. So there's different ways to do it. So if somebody is having irregular bleeding and you're trying just to regulate it so that they're having bleeding, but it's a little bit more predictable, you can give them a regimen to try to have a monthly period or a monthly withdrawal bleed. If you're trying to suppress periods and make somebody not have a period at all, then you do daily, continuous. There's different ways that you can do that. And whatever is working, I tell patients, I say, whatever we choose to do is not a forever decision. So it's a visit-to-visit decision. So this is not necessarily what you're going to be doing 20 years from now. But on the flip side, whatever's working, particularly in perimenopause, whatever's working today for the next few months, your body's going to be changing. It's going to be a lot different. So 6 months from now, it may not, like what we're doing right now may not be the best option. So come back and see me, don't get discouraged and just say like, oh, this isn't working.
Right.
So until we get to the other side, and you're to the other side, truly postmenopausal,
right.
You're up and down, and you're up and down a lot.
Right. And so if you are perimenopausal, and let's say like you're on a menopause or progesterone pill for part of the month, do you have to be on anything estrogen wise, or is your body just, are you not worried about the estrogen part as the gynecologist?
So it's okay to take a progesterone or a progestin without an estrogen.
Okay, gotcha.
But it's not okay to take an estrogen without a progesterone or a progestin if you have a uterus.
Okay.
So for some people, their estrogen hasn't started dropping much yet. Mm-hmm. So if I give those people extra estrogen, particularly on the days of the month that their estrogen is high, I give them so much that they don't feel as good.
Right. Does it make people angry?
Everybody's different.
Yeah. Okay.
With how they respond.
Yeah. Okay. And you determine that really based on symptoms as to how you're going to treat that.
More so than labs.
Okay.
And I do occasionally do some labs.
Okay.
But I usually do labs if what somebody's telling me doesn't add up to what I think they should be telling me.
Okay.
Based on what they're on or where I think they are.
Right.
So, in a woman who's having a cycle, if I know where she is in her cycle, I can kind of tell you if her hormones are going to be, high, medium, or low.
Sure.
I may not can tell you the exact number, but
right.
So you don't always have to do lab work. But we use labs a lot, but it's not. I'm not chasing labs.
Yeah. And same thing with menopause. You really don't check labs unless are you doing a lot of rule outs or?
So, once somebody is truly menopausal, and so that's when your ovaries have shut down, mm-hmm. and let's say they're already through the fluctuations and the up and down, and they're just leveled out, where they're going to be. Then the big symptom that people have is low estrogen. So mm-hmm. it's hot flashes, it's night sweats, it's brain fog,
right?
It's muscle aches and pains, and to replace that estrogen is going to help most people feel better. If I have somebody in front of me and they're like, oh, like I'm miserable, whatever, I'm like, I can make you feel better by the weekend.
Mm-hmm. Right.
And so there's lots of different reasons that we take hormone therapy after menopause, and the big one is to feel better.
Right.
And then we get to the point where 80% of people don't necessarily need hormones to feel better. And where the controversy starts coming in is, should someone take hormones even if they don't necessarily need them to feel better? Mm-hmm. And so that opens up the whole world of all of the good and the controversy of hormone therapy. And so, we know unequivocally that estrogen is protective of bone. Mm-hmm. So women start developing bone loss and start losing bone really in that perimenopausal time mm-hmm. as well, but particularly after menopause, and we get a rapid decline within those first few years after mm-hmm. menopause really hits. And it's unfortunate that a lot of the guidelines are for bone density testing to start at 65. Well, if the average...
Is that right?
Yeah.
Oh, I had no
idea. We test everybody much younger than that.
Yes, I know.
If you really look at a lot of the guidelines, it start testing every 2 years at 65.
Yeah, I think that's crazy.
So the time that people are going to have their rapid decline is typically in their 50s. Mm-hmm. So in their early 50s, so right around menopause.
Yes, and okay, so I do want to talk more about what you said about how long we should be on hormone replacement therapy, but I guess I did have a question just, about bone loss, and is it something that, like, let's say you're in your typical person is in perimenopause, let's say at least in their mid-40s, maybe even earlier. Is this something where if you're doing all the right things, like you're, not smoking, you're doing exercise with, I guess, weights maybe is better,
Yes.
and
Heavy
you're
weights.
doing all those things, that is going to help improve your chances the second that you get that knocked with that, bye-bye, estrogen's gone. Like, is that something, or is that just good habits that are going to lead you into? Or can you explain that to us?
So if we look at bone density, so we are increasing our bone density and we peak in our early 30s.
Okay.
So the two big times of life that you can affect a change in your bone density is as you're building, particularly your teenage years.
Okay.
Is to build your bone. So you peak at a higher level.
Okay.
If you have good health bone habits, getting plenty of calcium, getting plenty of vitamin D, strength training, all of those things. So we peak at a higher level. So if that's why with like teenage girls or athletes, if they're not having periods and they're not making enough estrogen, they may peak in their 30s at a much lower level than their peers. Certain groups of people. So that's why in those teenage years, you're trying to keep those young girls to where they peak at their bone density at a higher level.
Okay.
Because we all start losing in that perimenopausal time in our mid to late 40s. And then after menopause, average age 51, you have a rapid decline. And then we level out. And once we get into our 60s and 70s, 65, 70, where we've leveled out is kind of where we're going to stay. And so there's not really a whole lot of change you can do. But to really prevent that loss in the early menopause years with estrogen is the big key. Is a big key. There's no question about that estrogen.
Yeah.
And people don't take bone health serious.
Right, I agree.
They think about everything else. People are worried about breast cancer and they're worried about but heart disease is the number one killer of women, so we need to be thinking about heart disease. And then we need to be thinking about if you make it into your mid-80s, if you have an osteoporotic fracture,
Right.
30% of those women are not still with us a year later.
Right.
And it's not that the hip fracture itself is lethal. It just starts this snowball of things that 50% of people don't go back to their same level of independent living that they did before if they fall and break a hip or they break a hip. And then it kind of snowballs, and then they become less mobile, and then they become more more fragility, and they keep going, and then they wind up bedridden, and then they wind up in a facility, and it just snowballs.
So I do have a couple of questions about bone health. So one would be, if you are an extreme athlete, is it actually detrimental for your bone health? And another thing would be, so you said we have this kind of rapid decline. Let's say you're 50 and you go into menopause and you have this kind of rapid decline. But then there's those several years, like say you've gone into menopause at 52, but most people have like a fracture in their 70s. What can you be doing during that time period to build your bone? Can you build your bone
estrogen
back up? What's that?
Stay on your estrogen for your bones.
Yeah.
So you can prevent that rapid decline with estrogen, but if you stop your estrogen, you're going to have that decline, but it'll just be later on down the road. So whenever you stop your estrogen and lose your estrogen, then you get the rapid decline in your bones. Now there's a lot of other medications that we can use for osteoporosis.
Yes.
So there's some things that we can do to try to build bone, but the lifestyle things, plenty of calcium, and it's always better to get your calcium through your diet, so not a supplement, but if you don't get it in your diet with the foods you eat, then you need a supplement.
Yeah.
Calcium, vitamin D.
Would you say most people aren't getting it in their diet?
Well, it just depends. It depends on how much calcium.
Okay. I was just
I may have said that,
like
but many people don't.
Yeah, I was going to say.
You have to eat quite a bit of cheese, and milk, dairy
yeah.
products to get enough calcium.
Yeah.
So you need 1,000 to 1,500 milligrams a day. So if you're on estrogen, you're menopausal, you need more like 1,000. And if you're postmenopausal and you're not on estrogen, you need closer to 1,500.
And you need the vitamin D.
You need the vitamin D.
People need to know that, like 400 to 800 or something.
Yeah, we usually say a little bit more 1,000, and it's seasonal, so you're lower in the winter and spring, and higher in the fall and summer because you've just been in the summer for people in this community. Most people get some sun exposure,
right?
So it kind of depends a little bit on the time of year that you check the vitamin D, but make sure you're getting plenty of vitamin D. And then strength training.
Yeah.
So someone who runs, who's a runner or a swimmer, if you don't do anything that's weight bearing, then your exercise is not as good for your bones.
Okay.
And then the other thing, we have a lot of people losing a lot of weight with GLPs. So the one thing they have to think about is their bones. And so about the only thing that is not better for your health when you lose a significant amount of weight, if you have that weight to lose, is your bones. So your joints is better, for heart disease, everything else it's better, but actual bone density, if someone loses 40 or 50 pounds, their bones will show it. Their next bone density is usually lower because they're not carrying that extra weight around.
Yeah. Wow, that's scary.
Yeah.
That's good to know, though. Well, so, okay, let's talk about, I know we're going to talk about testosterone a little bit too, but let's talk about who are the people who cannot take hormones?
So,
and what are your recommendations as to when to stop?
So, those are really good questions. The three big benefits to hormone therapy, besides, the two big benefits to hormone therapy, besides helping someone feel better with what they need to feel better. So one is your bones, and then the other is heart disease protection.
Okay.
And so, unfortunately, that's where a lot of women have missed the boat because after the Women's Health Initiative,
I remember
the big study that was misrepresented to the public, scared everybody
to death,
made them flush their hormones, and we were like banging our heads against the wall trying to get people to take hormones when they needed them to feel better because they were listening to this public. It wasn't social media back then. This was in the early 2000s, but they were listening to the media and the public opinion, and people were flushing their hormones. And then the last few years, we have revisited that, and thankfully, it's not so much that our information has changed. It's that we got the correct message out to the public, and public opinion has changed.
It has, and I don't know how.
And then there's more studies that have just reinforced what we knew back then.
Right.
So it's not really that things changed as much as it was just the opinions and the education for people changed. Now it's almost the other way where people are coming in thinking that hormones are going to fix everything. But the other big benefit to hormones is cardiovascular protection. And so for women who continue their hormones through that menopause transition into their 80s, or at least for several years after menopause, 10 to 15 years after menopause, they have a significant reduction in cardiovascular deaths. And so estrogen has effects on the blood vessels, so your arteries, and they will help keep them softer and pliable.
Okay.
And if you start taking your estrogen or keep your hormone levels up, so in your reproductive years, your hormone levels are up, and really for the most part in your perimenopausal years, they're up, and then at menopause you start dropping. Well, that's when women's cardiovascular risks start going up, and so women start having all their heart attacks in their 60s because they lost their estrogen in their 50s.
Right.
So if we get somebody within 10 years of menopause and less than 60, unless someone has a lot of already cardiovascular disease and risk factors, then estrogen is heart protective. So your blood vessels are still pliable and flexible, versus someone who is in their 70s and they already have some atherosclerosis or hardening of the arteries or calcium buildup, so they've already got hardened blood vessels, then the estrogen won't fix that.
Right. And it can make you prone to clot a little bit.
So estrogen also thickens your blood.
Okay.
So estrogen's a blood thickener, and there's a protective effect of thickening your blood. And high levels of estrogen are, pregnancy and postpartum, and then when women bleed, and there's some built-in Mother Nature protection to try to keep you from bleeding to death.
Yeah.
But that estrogen will thicken your blood. And if you've already got cardiovascular disease, then taking an estrogen or starting an estrogen, more so, not taking it, but starting an estrogen can cause more adverse events.
Gotcha.
And that was the problem with the Women's Health Initiative back in the early 2000s. When that study came out, the average age of those women was mid-60s. And in our society, a woman in her mid-60s, the average person already has some cardiovascular atherosclerosis. And they started those women on an oral estrogen, and they were hormone naive, meaning they hadn't already been on hormones.
Right.
So they started a woman who already had heart disease brewing on something that thickened her blood, and they caused a few more events.
Gotcha.
And that was where then the message that went out to people was, and even other physicians, was, oh, hormones cause heart disease. They're not protective.
Right.
Well, if you really look at it, if you've been on your hormones since menopause, they're protective.
Gotcha.
They're still
it's
protective.
Making your vessels
and
more
then it's
pliable.
keeping your blood. I guess that's to say keeping your blood vessels more pliable. And then we get into the route of getting your estrogen. And so bioidentical gets thrown around a lot, and it's used for a lot of marketing. Billions of dollars are spent for bioidentical hormones, but bioidentical means more in the form that your body uses or your body makes. And so in hormone estrogens, we usually talk about oral versus transdermal.
Right.
Is the big one. So oral by mouth, transdermal means by skin. So a patch, a gel, a spray, a cream, and that can be compounded. It doesn't have to be compounded, but it can be compounded. And that's where a lot of the compounding places, promote bioidentical, but you can get a bioidentical safe, FDA approved product by prescription. Pellets are also bioidentical. I don't do pellets because you can't control that, and there's no reason to, because I've got lots of good, safe alternatives. But if we're talking about route of estrogen, and we talk about transdermal, the patch, the gels, the sprays versus oral, there's some differences. And the issue with taking an oral estrogen is you take it, it goes to your liver breaks it down, and then it goes out to the body through the bloodstream in the broken down form, and then it comes back again through the liver for the second time.
Okay.
So if you take an oral estrogen, you make 2 trips through the liver.
Okay.
That first trip through the liver affects the liver. So it can affect some of the metabolic factors, and there's some thought that there's some benefit to that. So it has a better effect on lipids and insulin resistance and diabetes. So for some of the metabolic effects, you get a little bit of a benefit from an oral estrogen.
Okay.
But that first trip through the liver also affects the clotting factors, because estrogen in that first trip stimulates the liver. And so when it stimulates the clotting factors, there's a little bit of an increased risk of blood clot.
Okay.
If you are doing a transdermal estrogen, so patch, gel, spray, cream, it doesn't make that first trip through the liver, so you don't have as much of a beneficial effect on like your lipids and
cholesterol,
insulin and all of that, but it does not adversely affect the clotting factors.
Okay.
So particularly somebody who is at risk for a blood clot, or if someone already has a concern about having thicker blood, like for cardiovascular atherosclerosis and those kinds of things, then you want to make sure that you have them on a transdermal estrogen. So my general rule is by about 60, I try to get people off on something that is transdermal. If somebody's willing to do transdermal earlier, it's just usually less convenient because you don't get the progesterone. You still have to take a progesterone pill, and there's some nice options that are combined pills, and it's just almost easier for people to take a pill.
Right.
But But, the transdermal is what we usually keep people on long term.
What about hormones with breast cancer issues?
So a lot of controversy with hormones
Okay.
and estrogen and progesterone. And estrogen in some ways has gotten a little bit of a bad rap with breast cancer. In that early study, they gave women Premarin, which is not it is a more synthetic estrogen and not as much of a bioidentical estrogen like the estradiol is what most people use now.
Right.
But that Premarin and Provera, so you were getting a synthetic progestin, and you were getting Premarin, which is a conjugated equine estrogen, and it was a pill form.
So a synthetic estrogen and progesterone.
Yes.
Okay.
Both.
Gotcha.
And that was what most people used back in that day.
Yeah.
In the women who were on the combination of both of those, there were, out of 10,000 women, there were 8 additional breast cancers.
Okay. Which is not very many.
It is not very many.
Yes.
And
I remember those numbers now.
8 out of 10,000 women.
Yes.
If you look at the colon cancers, there was like 7 fewer.
Okay.
So for some of the things, it was kind of tit for tat.
Okay.
But the whole media focused on the breast cancer, or women are afraid of breast cancer and fearful of that. And so that got latched onto.
Right.
So 8 additional out of 10,000, which is not really a lot.
Right.
When you look at the Premarin only arm of the study, so they stopped it early, and that was like in 2002. And then like a few years later, 2005 or 6, is when the women who had a hysterectomy who were on the Premarin only arm, the estrogen only arm, so they didn't need the progesterone, progestin, the Provera, because they didn't need the uterine protection. Well, those women had actually fewer breast cancers than the controls.
Okay, that's
and
interesting.
that got like the bottom of the back page. That didn't get like the nobody talked about that.
Right.
So what we concluded from that was that it's the Provera, and it was with long-term postmenopausal use.
Okay.
There were some additional breast cancers.
Okay.
So for the average person who's taken hormones for at least a few years to get them through the throes of menopause when they feel so bad, breast cancer, if they don't already have breast cancer, but breast cancer and the risk of breast cancer is not really a problem.
Okay, so 2 questions with that. One would be, you have a female that has a very strong family history of breast cancer. Would you tell them don't take hormones?
There is not a family history of about anything that I can think of that would cause me to deny someone hormone therapy.
Okay. And second question, the follow-up question to that is, you have a woman who definitely has had breast cancer, and she got the treatment, she got the whatever, surgery, whatever, all she had to have, the chemo or the pills, or what do you do in those situations?
So that one is a lot more complicated.
Okay.
That's a lot more complicated. So
you may say no on that.
Correct.
Yes.
Correct.
Not always, not 100%, but
so it is. Our big medical term is shared decision making. So it's having a discussion with someone, and particularly if their breast cancer was estrogen or progesterone receptor positive, to give them something may stimulate that.
Right.
And we know that taking an estrogen blocker, an anti-estrogen or estrogen blocker for the breast lowers breast cancer risk in people. So I'm not. I feel like that estrogen plays some sort of a role with the breast as well as the progestin. European studies. So typically I don't use the Provera. Certainly not long term with someone. Without having the discussion to say that was the hormone that was studied, that there were some additional breast cancers with long-term postmenopausal use.
Okay.
So I have that discussion with people, and occasionally we've sorted out, and that's the better option for them. There's a lot of questions that those of us who practice menopause medicine have, like, this combination or this one or that one, or what if we do this and that? And we're never going to get the answers to, because there's too much controversy for a lot of those studies to be done. But there are some European studies, and they have not found the same issues with the micronized progesterone as we found here with the synthetic Provera, hydroxyprogesterone, acetate. So there's a lot of unanswered questions that we all have too. And so there's a lot of things that we do where it's, well, we're doing the best we can with what we have. And, you know, if hormones cause breast cancer, when all the women flushed their hormones in the early 2000s, all the menopausal women, we should have seen breast cancer rates go down. Well, we haven't. They just keep going up.
Why do they keep going up?
I don't know on that.
Yeah.
Yeah, that's the big, I don't know, is it something environmental? Is it something?
I didn't know if it was better detection or...
I mean, there is some question about early detection. You know, are we just picking it up early and it looks like people live longer, but in the end, do you really? So there's there's a whole lot of, questions that we have with that. Yeah,
we'll definitely have you back to talk about a breast cancer. That could be
that's a whole other topic.
Oh my gosh, yeah, that's a huge important topic. Okay, so all right. Couple other questions. We talked about, I definitely want to hear what your thoughts are on testosterone. And I also want to hear your thoughts on, as you were talking about, when you get older especially, but even, you know, if you're in your 50s, you have the vaginal dryness, and it can contribite to infections and urinary tract infections, maybe bacterial vaginosis.
Absolutely.
And so how do you treat that? And if it is estrogen, do you can use that with oral estrogen too?
Absolutely. So many times you need it in addition. So treating with estrogen therapy locally in the genital urinary area, vaginally, is not the same as systemic hormone therapy. So it doesn't have the same controversies, and it doesn't have the same benefits. So it does not help protect your bones. It does not protect you from heart disease. There's no dementia benefit. There's also no concern with breast cancer. There's no concern with clotting. There's no concern with cardiovascular disease. So you look at that as completely separate. And thankfully, back in November of last year, there was a lot of people speaking in front of these FDA panels trying to get some of the product labeling changed, because up until recently, all hormones, whether they were estrogen or progesterones or a combination, had the same package insert. So we were telling patients one thing, and they would go home and look at their package insert, and we may be giving them something that had absolutely no estrogen in it, but their package insert talked about their hormone like it did, and then it caused a lot of distrust. You know, they didn't believe what we were saying, and that packaging was completely incorrect. So thankfully, that's being changed. That is being changed, and some of the black box labeling on hormone therapy has been removed. So we're making progress. Making good progress. I tend to think that almost every woman should have some vaginal estrogen.
I was going to ask that.
So the benefits, so it helps for any sexual activity and to help with vaginal thinning and vaginal dryness. It also helps with urinary tract infections, vaginal discharge. You know, there's the thought, if the little ladies in the nursing home got a little dose of vaginal estrogen a couple of times a week, that we would cut down on urosepsis, and, you know, they would be much healthier. It's much better. A couple of different ways you can do vaginal estrogen. One way is with a cream. It's a little bit messy, but it's a cream, a tube that comes with an inserter, kind of like that you use for yeast medicine. And you squirt some cream in the end, and you put it in like a tampon and push a dollop in. And then you also can just put some on and just rub it around on the external genitalia, so the labia and the introitus, the opening of the vagina, and the urethra where you pee. So just rub it around twice a week. There's also some vaginal tablets, inserts. So there's one that looks like a little, I always call it a candy corn shaped chiclet. That's what it looks like. So it kind of is, it's shaped like kind of like candy corn, and it has the consistency of like a chiclet. Then there's some that are tablets and just different ways to get some estrogen vaginally.
Do you
a couple
see
times a week.
that? Like I mean, I know you don't really go to the nursing home, but I mean, do you hear providers trying to get, because I do feel like that's a huge issue for people in nursing homes, for
No,
women.
I don't hear about it very much. And most of the people that are coming to me in my office
Yeah.
are not
Right.
are not capable of getting in. So that's not the population of people
Right.
that I see.
Yeah.
But I know that it would be beneficial.
Oh, for sure. Yeah, it's interesting because we just did a nursing home talk on the show. And so it really made me think about that. So
You could, yeah.
And I did have a question too. You said something a minute ago about, speaking of nursing homes, so is there some proof that estrogens can help prevent dementia or
So
stave it
the
off?
final answer is not out on that. All of us want estrogen to be one of our magic bullets.
Mm-hmm.
At last year's Menopause Society, the talks on the dementia and the cognitive protection was not quite as strong as what we have prior thought.
Okay. Study-wise.
But and that is not for someone who has early menopause. So what we've been talking about is someone who has menopause at the average age, mid-50s.
Right.
A whole different group of people is people who have early menopause. And absolutely those people need to take hormone therapy at least until the average age, or they're going to be 8 or 10 years aged ahead of their peers with their heart, with their bones, and with their dementia. So early loss of estrogen, definitely there's some dementia concerns and taking estrogen early. But, to continue taking estrogen like it helps to continue to protect your bones, I'm not sure what the right answer is on that.
Okay. Wow, that's so interesting.
I'm
So
gonna
they
keep
know that about early menopause, that you could be more prone, but they don't really know.
We're not fully there yet.
Okay.
On that answer.
Okay.
I'm going to keep taking my estrogen until I go to my grave.
Yes, I have to say, I know maybe the breast cancer thing is a whole other discussion, but in my family I have no relatives, thank goodness, that have that. So I kind of feel the same way about my hormones. I'm very, very happy with them on so many different levels.
And people are worried. Dementia is another big thing, but people are so worried about, like for breast cancer, they're worried about hormones and taking hormones. Well, alcohol is a big risk factor.
Right.
There's so many other things in our life that are bigger risk factors than hormones that nobody wants, all of the, the lifestyle and the weight and all of those things. And then people are afraid of hormones. But I think hormones are something easy to, in years past, have been easy to blame.
Right. For sure.
Been easy to blame.
Yeah.
And then, thankfully now the pendulum is going in the other direction. So I have people coming in thinking that hormones are going to fix everything, or they're trying to blame everything on hormones. And it's really easy for me because I can say, okay, well, we'll try it and see. So if taking hormones helps you feel better, then great. And if taking hormones doesn't really fix it, then it probably is not hormone related.
Right.
It's probably not hormone related in that way. But women need to find someone who will listen. And the Menopause Society is the governing organization that many of us who practice a lot of menopause medicine follow the guidelines. I think most of us think that they're a little bit too conservative and that they should go a step further, because most of us think that there's more long-term benefits to continuing to take hormones. They still will say take hormones to feel better is the primary reason to take hormones. I counsel my patients that I think they should take hormones at least until they're 60, just for the health benefits. And that's going a step beyond what the Menopause Society says. But you mentioned the Menopause Society practitioners. So the Menopause Society, they have on their website a list of providers, and it's people who put themselves out there as being interested in menopause and willing to listen and more open to hormone therapy and treatment with hormones. you don't necessarily have to be certified. If you are, quote, certified, that means that you have taken a test, passed a test, and that you do continuing medical education in the area relevant to menopause. So you don't have to find a provider that has to be menopause certified, but at least find somebody that's willing to talk to you and listen and give you hormones and have that discussion.
And you're saying that is, and I think I may have even seen that on you guys, your practice website, that you are a certified practitioner, but you're saying
there are several of us that are.
Right.
I mean, there's a lot of people in my practice that practice good menopause medicine that haven't like taken the test.
Okay.
I have.
Yeah.
We have, there are a few of us that have studied for and taken and sat for the test and passed the test and do continuing education, but there are plenty of people who still practice good menopause.
Yes.
You'll have to. Do we have time to talk about testosterone?
Yes, we do. And after that, I was going to say, maybe let us know what screenings we need to be doing in menopause. So yes, let's start with testosterone.
Well, testosterone. So
I had a terrible experience, by the way.
Well, so testosterone is
Yeah.
Losing your testosterone is not really a menopause phenomenon. It's an aging phenomenon. So it doesn't drastically drop with menopause. It just goes down as you age. For women. Okay. So people come in and they say someone to have their testosterone levels checked, and if they're certain phase of life, I'm like, well, I can tell you it's going to be low.
Right.
There'd be something wrong if it's not. Now the PCOS folks, they have more testosterone, so sometimes they're not as low.
It's polycystic ovarian syndrome.
Ovary. Yeah, the polycystic ovary syndrome. Those people sometimes are higher. But so almost everybody's testosterone is low. And there's some decent evidence that replacing testosterone, particularly in someone who has low testosterone, and that's essentially every menopausal woman, can help libido.
Right.
So libido is a whole big topic that, that we're all searching for the answer for, and there's no good solution for that. But there's also people who with testosterone feel that they have more energy and that they just overall feel better. And so with testosterone, I check a lot of labs, not so much to check labs to see where someone is. It's if I'm putting them on testosterone to follow them.
Okay.
So I do regular labs for women who are on testosterone. Okay. And I try testosterone with lots and lots and lots of people because everybody's heard about it. Everybody's got a buddy that just thought it was magical. And every once in a while, I'll have somebody who like really loves how they feel on it.
Yeah.
But a relatively small percentage of people that I start testosterone with stay on it long term. Okay. Because most people are like, well, I don't really see that it makes that much difference.
Interesting.
Like not that much.
Is it almost always a cream?
Yes.
Okay.
A cream, or I don't do pellets.
Okay.
But testosterone is not absorbed. There's one really old that I haven't started somebody on in years and years with an oral testosterone, but it breaks down and you don't really absorb it. So testosterone is almost always a cream or a gel, or in some countries they have a patch. And I've been hearing about the Intrinsa patch. That's a testosterone patch for women that's coming since, I don't know, I started doing this in the 90s, and it's still not here.
Oh, interesting.
But with testosterone, there's side effects of testosterone. So
I think I had those.
Oilier skin, acne. And then if you get up to a little bit higher levels, you can start having increased facial hair. You can have hair growth in places you don't want it and hair loss in places that you do. And then you can have clitoromegaly. So, and then the one thing that I warn everybody for with testosterone therapy is that they can have a thickening of the vocal cords and a deepening of the voice.
Oh,
that may not be reversible with stopping. So essentially everything else is reversible. I've never had anybody have that.
Okay.
But I tell everybody, so if they, if they're a podcaster, if they use their voice, if you're a singer, if you just speak in front, if you're a lecturer, if you're a teacher, if you just speak in front of people or talk on the phone, if you're
generally, who wants a deep male voice? I mean,
well, and it's really hard. It gets really annoying if someone, every time somebody hears them on the phone and they assume that they are a different gender than what they are, then that gets annoying,
that can
or
be,
just hear you talking. So that can be fun. But I've never had anybody have that. But The libido, so that's a big one. So who wouldn't take a little bit better libido? And
If you have a partner, right?
If you have a partner.
You don't want the
and the partner issue is a big cause of a lot of people's libido problem. But so if you think of your libido pie, this is how I describe it to people. So I say that we have like our libido pie, and we have different wedges. And one wedge is medical, and one wedge is hormonal. And after menopause, the hormonal wedge is a little bit bigger. And one wedge may be, your relationship with your partner, if you have a partner. One wedge may be stresses at work, and one wedge may be body image. And so you have all these wedges that make up your libido pie.
Sure.
I can make your hormonal wedge perfect.
Sure.
But it may not compete with everything else.
Right.
So I think that's why that many people don't really see that big. They don't always see enough of a difference in their libido to keep continuing the testosterone.
Right. Right. Because if you don't have any interest in your partner for a billion other reasons, then it doesn't make any difference.
It doesn't really matter.
I don't know why they would be asking you unless their partner is maybe like pressuring them. But I did have a question, just because, and I'll tell you what my side effects were with the testosterone. But I did wonder, like, do you see, like, if someone is having adverse side effects, that their labs are generally a lot higher, and then maybe you just back the dose off a little, or what do you do with that? Or
that we start following the labs more closely.
Okay.
We start backing it down.
Yeah. Okay.
And some people feel more anxiety, more anger, and they feel more moody things, like irritability with testosterone.
I had a lot of anger, and I also was losing weight rapidly. And of course, this might be something that people are like, oh, I would love that. But literally, I thought that I had cancer. Like, I was really worried about it. And I think I got put on it around the time that I was having, some just menopausal symptoms too. So I'm having night sweats, and I think I'm having cancer because I haven't changed my diet really. And all of a sudden I've lost 5 pounds. And yet for me, it was like very distressing. And, it's just, do you see much of that? Complaints of like anger and weight loss?
Well, I never see weight loss, but
that's interesting.
But usually it's if it depends on which side of the fence you're on. So if somebody has weight to lose, they gain. And if somebody is on the underweight, not necessarily for testosterone, but kind of with other things, it depends on which side of the fence they're on. So if they have a propensity to gain weight, with stress, they stress eat. And if somebody has a propensity to be thinner, if they have stress or whatever, then they tend to not eat. So,
this was confusing. I mean, because I didn't feel like I was doing anything any differently, and I was losing
I guess
weight.
Weight loss is not one that I commonly see, but the irritability and the aggression and anger and anxiety and not being able to sleep for some people. Yeah. The one plug I will say for testosterone is that it helps maintain muscle mass.
And that may have been part of my weight too. I don't know. I was building muscle. I don't know more, because doesn't that help you lose weight basically?
Well, it can, yeah. But it can make your metabolism a little bit better. The more muscle mass you have, the better your metabolism. And so for bone health, so there is potentially some benefit. And right now, it's not a generally accepted treatment for bones. Bone loss. It might in the future. I don't know. There's some good evidence that testosterone helps protect bone.
Interesting.
Helps with bone. But right now, it's not one of our ones that I use specifically for that. But it's an added benefit if somebody likes testosterone.
Yeah. All right. Well, let's round things out with just how long do you keep doing mammograms, pap smears, well, you name it, all the screening for us as we get into the menopause area?
So there's really only a few cancers if we're talking about cancer screening. So cardiovascular screening is a whole nother conversation. But for cancer screening, and those are the big things that we do. One is pap smears, mammograms for breast cancer. So pap smears for cervical cancer, mammograms for breast cancer, and colorectal cancer screening are the big three. Right. And so pap smears, we don't start until 21. And then
Even if they're sexually active.
that's what the guidelines are now.
That's
changed from when you and I were in medical school.
Okay.
It's
okay.
different.
Yeah, I didn't.
And it's
I
hard
didn't
for
realize it
me,
had changed.
an old dog, to get
Yeah.
on board with all the new stuff.
Yeah.
So the guidelines have changed. So
Okay.
even if someone's sexually active, it's not recommended now that
Okay.
someone start
Okay.
pap smears until 21.
Okay.
And just because somebody has a pelvic exam does not always mean that they had a pap smear.
Okay.
So when we say that someone may not need a pap smear every year, that does not mean that they can skip their annual well woman visit and
Okay.
skip us examining them and looking. And that's a big distinction. So
Right.
people need to know that. Like, you still need to go. There's a
Go
lot
to
of
your
stuff
doctor
that I
every
pick
year.
up just because
Mm-hmm.
I'm talking. And I think a lot of people see physicians and they don't always get examined as thoroughly as we do,
Oh, absolutely.
because we're examining
A lot of
parts
your-
of the body that nobody else wants to examine.
a lot of your primary care don't want to do a rectal exam.
Yeah.
Anyway, go ahead.
Yeah. So pap smears.
Yeah.
So the guidelines have changed. And I jokingly tell people, I don't know how often I'm supposed to do your pap smear because they keep changing it on me.
Yeah.
But we have seen the cervical cancer rates go up a little bit.
Okay.
So I do regular paps
Mm-hmm.
every 1 to 2 or 3 years
Mm-hmm.
up until at least 65.
Mm-hmm.
And this is assumed when someone has a cervix. So if someone has a hysterectomy with their cervix removed, unless they had their hysterectomy for cervical cancer or they had high-grade dysplasia, they don't have to continue to have pap smears.
Okay.
But we still look and we still
Okay.
examine.
Mm-hmm.
And I go to every couple of years after 65.
Okay.
The other big thing that we do with the PAP is HPV screening.
Mm-hmm.
So I do just a label that I put on the PAP bottle. So you
Okay.
collect it the same way,
Mm-hmm.
but it's a label that I put on the PAP bottle. And I do that every 3 to 5 years.
Even if the person's
30
monogamous?
Yes,
Okay.
I do, because 30 to 65.
In case it didn't get picked up.
It may
On
not
a-
have been
yeah,
picked up.
Exactly.
Yeah.
Yep. Or they could have had a partner that did something and they didn't know.
Or something that they have had that hasn't been detected,
Yeah.
and their immune system has changed and something has flared up that
Yeah.
they have gotten. So with particularly HPV, you can't make any kind of an assessment of someone's
Okay.
fidelity or
Okay.
what somebody's been doing. So,
Gotcha.
Um,
Okay.
Then we talk mammograms, and that's
Okay.
really evolving and changing. So we are in the process of expanding who we identify as high risk for breast cancer and what we offer them.
Remember you
So-
told me this.
For mammograms, every year,
Mm-hmm.
starting at 40
Mm-hmm.
for the average risk woman,
Mm-hmm.
I continue those all the way up as long as someone is coming to see me. So
Mhm.
if someone's in the nursing home,
Mm-hmm.
they don't need to be trying to get a mammogram, I
Mhm.
guess. But the people that are healthy enough to be coming to see me for a wellness visit,
Okay.
if they're 90, I'll get
You'll do it.
mammograms.
Every year still?
Yeah,
Okay.
yeah, I do. Absolutely.
Okay.
And what's changing is how we are using some of our questionnaires
Mm-hmm.
to identify high risk folks.
Mm-hmm.
So what we use in my office is a model called Tyracrusic, which is just a series of questions that gives a calculated lifetime risk of breast cancer.
Okay.
And so a woman's average risk is 1 in 8, which is 12%.
I knew it was one.
So
in
we
eight.
say 15% or less is average risk.
Okay.
We say 15 to 20 is intermediate, and above 20% is high
Okay.
risk. And we also now are using the specific mammogram breast density.
Mm-hmm.
So whether someone's breasts are extremely dense or heterogeneously dense
Mm-hmm.
as part of that.
Okay.
And so a lot of people are being offered a breast MRI yearly in
Okay.
addition to a yearly mammogram as part of their screening.
Will insurance pay for that?
It just depends.
Okay.
In my 30 years of doing this, it always takes insurance companies a few years to get on board.
Sure.
So for instance, when we started doing 3D digital or the Tomo mammograms, the better technology for the mammograms, it took insurance companies a few years. Now that's standard of care.
Mm.
So when we first started doing that and we offered that, we had to have people pay a $50
Mm-hmm.
out of pocket to cover that because insurance didn't cover it, even though it was recommended, even though it was the guidelines, and even though we had the technology.
Yeah.
So I think it'll take a while. The
The difference is that there are things that mammograms pick up that MRIs don't, and then there's things that MRIs pick up that mammograms don't. So it's both and, it's not either or.
Okay.
And the big thing that the MRIs pick up is the vascular changes of early breast cancer. And the problem with the MRIs is that gadolinium is the contrast media that's used, and it's getting better. That's what the radiology folks say, is that the gadolinium that we use is getting better, but we don't necessarily clear that every time you get a scan. And it collects, and one of the areas it collects is brain and bone and different areas of the body. And so we right now don't have long-term evidence that yearly gadolinium exposure in a healthy young person has any problems or doesn't have any. So there's not data to show that there's a problem. But there's also not data to show that it's safe either.
That's good for the listener to know.
Yeah, it is.
When
So
you're
it's
making that decision. Yeah.
So if we have on blinders and we're just looking at breast cancer, then by all means, doing MRIs can pick up more breast cancers and pick them up early. But if we're looking at the overall total woman, I don't know if dementia or glioblastoma, I don't know if that's I don't know.
Right.
So sometimes with folks, I'll say like, well, let's maybe do it once, but let's not do it every year. But if you're really going to do it, it's every year alternating 6 months from your mammogram, so that every 6 months you're having something.
Okay.
And then I have some folks that are, high enough risk that they don't care. They don't care.
Right.
They don't care. So they want it every year if we can get it, and we'll do it.
Yeah.
There's a couple of places in the state that do IV mammograms. No place in Louisville that I'm aware of, but I have a couple of people, and that picks up the vascular changes, and I've had a couple of people willing to travel a long distance to do that.
Okay.
So sometimes, though, when we're doing some of these alternative things, it sounds really great, but the reality of somebody doing it, then it winds up being not as simple as what you think it's going to be. And then the colorectal cancer screening is the other one, and that age has been lowered to 45.
Okay.
And it depends on what method you're screening and what your history is. But the gold standard is colonoscopy. Cologuard, a stool test, is an acceptable alternative. But when we say, well, it picks up, 90+% of colon cancers, that's of 100 that were picked up from a colonoscopy.
Right.
So it's an acceptable alternative. And so, a poop in a box test and send it in is easier for some people than a colonoscopy. So I just want to get what somebody will get. There also is a blood test for colon cancer, and that one it's not really as good, and then we don't know what to do with the results. There's also some new blood tests that pick up early cancers that use some of the similar cell-free DNA technology that are screens for, like, you can do one blood test and insurance doesn't cover it, but it's out of pocket, and it will screen for early. Screen really means picking up precancers is how we use the screen for pap smears and cervical cancer and colon cancers with the colonoscopies, because you can pick something up before cancer actually happens. So it's a screen for early cancer. But it does like pancreatic and some of the lymphomas and thyroid and lung, and it's a blood test that you get that picks up several different markers, tumor markers, and proteins that are circulating in the blood.
Wow, that's interesting.
So that's relatively new, just like within the last year-ish or so. So I have a few people who, we try to get that information out so that people know that it's there, but that's not.
Right. Like, especially if you have like a strong family history of something. Yeah. It's good to know. All right. Well, I think that about wraps it up for my questions. What about you? Did you have anything else you wanted to?
I think I just appreciate you having me here and trying to educate more women about menopause and perimenopause, because if you live long enough, it's going to happen, and you don't have to suffer. We talked a lot about hormone therapy, but we have a lot of alternatives that are really good now for vasomotor symptoms that really work well. So particularly if you have, even if someone has breast cancer, we've got medicines now that we can use that really help them with hot flashes and night sweats.
Yeah, for sure. And all of that, I guess, it's, we would say to the listener, make sure you find a good provider who's up to date on all of these things.
Yeah,
and
that listens to you and that you connect with.
Right.
And,
absolutely. Yeah.
Yeah.
And I know you guys have a great practice here in Louisville,
well, thank
Kentucky.
you.
Women's First
Thank
at
you.
Baptist.
Yeah, Women First of Louisville.
Yeah, it's amazing. Well, thank you, Dr. Grader. Our
you for
post
having me.
call, you were right on target. You didn't miss a beat. I really appreciate you.
Well,
and thank you for your
having me.
time and
Yeah.
being here. And thank you, listener, for sticking with us. And I'm going to assume that if you are still here, this is a topic that is of interest for you for whatever reason. We just named about a bunch of reasons that could be. And it may also be of interest to a friend of yours. So please share this episode with a friend. And I am on YouTube. As I said before, please subscribe to the channel, like the video. I'm also on Spotify and TikTok. If you should need to email me, my email will be in the show notes below. It is notyourparentsamerica03@gmail. That's all one word, notyourparentsamerica03@gmail. And anything, questions, comments, concerns, if you have a topic that you would like us to discuss. We really appreciate you here. We could not do this without you. I hope you have a wonderful week, and I will see you soon.